Well, good morning or afternoon, as the case may be. This is Janet Walker from the National Wraparound Initiative, and I'm just going to review this first slide on working the webinar, then we'll introduce our speakers and take it away. You've had a chance to look at some of these things. I just wanted to highlight a couple of things. You will be muted. All of the audience members will be muted during the webinar until there is a question and answer period. If you use the menu that expands from the right of your screen, you can raise your hand to talk during the question and answer, at which point one of us will call on you and unmute you, at which point you will be able to actually talk. If you want to ask a question in the meantime, you can use the chat box that's also in that menu, and we will save up those questions for the question and answer period unless it's something sort of technical about the webinar, in which case we will try to solve that immediately. And probably the most important bit of information, the webinar and the PowerPoint will all be available on the NWI website very soon after the conclusion of the broadcast. We will send you an email with information about how to access that. So all of the web addresses and all of the PowerPoints, you can look at those later and print them or download them as you choose. So ready to get started with today's webinar. This is the fourth in our 2010 series from the National Wraparound Initiative. It's called Supporting Wraparound Implementation, Emerging Themes for Developing Your Program or System. And today our special guests are Bruce Kamrat from Wraparound Milwaukee and Michelle Zabel from the University of Maryland Innovations Institutes. And we're very grateful for them to participating with us today. So just briefly what we're going to go over this session, a little bit of introduction and overview. What do we mean by implementation support? What is the framework that the National Wraparound Initiative uses to organize its materials and our thinking generally about supporting implementation? And then just a real quick review of some resources that you can access through the National Wraparound Initiative and mostly through the website. Then Bruce Kamrat's going to talk about Wraparound Milwaukee, the implementation themes, and what Wraparound Milwaukee has done, some of the sort of highlights of things that they've accomplished in each of those areas, and some of the results that they've achieved in consequence. And then Michelle is going to again touch on some of those key implementation themes and describe some of the things that are happening in Maryland. So to begin with, for those of you who have been on some of the previous webinars, we started out with some broad overview and then spent some time talking about team practice and what it takes to get to a high level of quality at the team level. But anybody who's been involved in Wraparound knows that it takes more than effective teams. Although effective teams are necessary, they're not necessarily sufficient. That also you need a supportive organizational context. And that means that organizations who can provide the necessary training, coaching, supervision, and also that the agencies and organizations that are working together within a wraparound project or a system of care need to have a certain level of coordination and mutual support and collaboration. And then kind of just further up at the system level, you need a system that's going to be hospitable to wraparound. And most specifically, there needs to be obviously available funding, funding that can be used and deployed usually in new ways to support wraparound and to support the wraparound team plans and provide the services and supports that are needed. But also, in addition, you need a system that is ready to coordinate its efforts on behalf of wraparound, that can help teams carry out individualized plans, that can provide access to the wide range of services and supports and even the individualized strategies that are needed to fulfill wraparound plans. So when I got involved in this work, because research is my area, my colleagues and I were interested in trying to figure out how to provide communities with reliable data about how well their systems were actually organized to support wraparound and the particular areas of strength and challenge. So what we began with was some research that was qualitative research, where we went out and interviewed team members in wraparound programs, we used what we call the backward mapping strategy, which is talking to people who are sort of on the front lines at first and saying, well, in order to carry out wraparound in a way that's consistent with wraparound principles, what do you need in the way of support from your organization and from the system? And then we went to organization people and said, so in order for you to provide what's necessary for wraparound teams, what do you need from the system level? What kind of policies and what kind of funding and other sorts of supports? So that was the first effort that we made. So we put together a kind of we called it a conceptual framework, a sort of a taxonomy of what it was that we called these necessary conditions, what absolutely needed to be present in the organizational and system context in order for wraparound to work. And then we used our resources through the National Wraparound Initiative, where we worked with our advisors to create individual kind of survey items, essentially, that said, are these necessary conditions present in a particular community's context, or organizational and system context. So we created these items with our advisors from the NWI, and we have been since then used this data collection process that we've put together in 23 communities, and we call this the Community Supports for Wraparound Inventory. And through the data that we've collected in these communities, we've had several rounds of research that has demonstrated statistically the reliability and validity of the measure. And what we wanted to do was create a way of, again, assessing the community supports for wraparound that would be a strengths-based approach that would be efficient in that it would not cause a lot of burden to communities, that it would not be costly, and yet it would still provide useful information that would be available to communities so that they could understand kind of how they stood as far as supporting wraparound, but that would also yield high-quality data that we could use for research purposes. So what we have, the Community Supports for Wraparound Inventory, the way that we gather data for this, it's a web-based survey. So you go on to, it's currently on SurveyMonkey, and people from the community go on and answer these items that sort of ask about whether or not certain kinds of things are available or can happen in their community. So each item has a least developed anchor or description, sort of what a community would look like when it's in the very early stages of, or perhaps has not implemented wraparound at all, when the community has, well, the resources in the community and the stakeholders are working to support kids and families, but they're not doing it in any kind of coordinated way. They're sort of, everybody's doing their own thing, and there's not a collaboration. And then the far end, the fully developed system, is what a condition might look like when there's a complete, when there's a effective collaboration going on, where there's sort of seamless support for wraparound in the community. And so people from the community who were identified locally go on and fill out the survey. So one of the things that we most wanted to know, oh, and here are resources. Again, I'm not going to go over these, but they'll be posted on the website, so if you're interested in any of the technical detail around this, you can find that out. Okay, so one of the things that we were able to find out on the basis of gathering the data was that indeed the items or the support that was needed for communities did fall into these themes or factors of community support. And these are community partnership, which has to do with whether you have the right people at the table making decisions about wraparound and collaborating with each other to oversee the wraparound project. Then collaborative action has to do with whether these stakeholders have actually been able to move ahead as far as planning and taking concrete steps and actions to make wraparound happen in the community. Then an obvious one, fiscal policies. Is there sufficient funding to support the wraparound program and wraparound teams as they do their plans, and is the funding sufficiently flexible in order that wraparound can respond to individual needs for kids and families? Then service array. Do teams have access to the services and supports that they need to meet families' needs? This includes both formal services, clinical services, crisis support, and informal supports and peer support, respite, and other kinds of individually created supports where necessary. Human resource development, this theme has to do with whether we have the right people in the right jobs and the right working conditions for them, and then are they sufficiently supported so that they can become highly skilled in providing high quality, in carrying out their roles with wraparound teams. And then finally, accountability. This theme focuses on whether we're a community is gathering and using data that provides some feedback about whether or not they're actually doing a good job in providing wraparound and adhering to the wraparound principles. So when we get finished with our survey, we're able to report to people. Of course, it's important to know whether their respondents actually took the survey and whether those people are representative of the community. Then they get a total score on the CSWI, and this is can also tell them how they do in comparison to the other communities that have participated in taking the CSWI. Then for each of those themes or areas that I mentioned before, there is a score for that theme. And then for the individual items at a little bit level of higher detail, there's also a score. And then we also identify for them particular areas of strength and challenge, and also include the comments that respondents made, their open-ended comments. So if you were to do the CSWI, you would get, as I mentioned, a total score. So this is, I guess, what the first 14 sites that we did. And you can see that site 1, so the total score, I guess theoretically you could get a 0, total score of 0, or a total score of 160 if you got every most developed on every single item throughout the survey. But you can see from site 1 is 40, which is an average of about 1 out of a scale of 0 to 4 on each item. And that is at the very beginning levels of development, which is understandable in the case of this site when they were actually at the very beginning stages of implementing their wraparound project. And then the site, you can see it's actually, there are more sites kind of in the middle around the 80, which is just above and below 80, which is actually midway on our scale. And then a few sites approaching 120, well, not quite, but getting there, which is a 3 out of 4 on the scale across all of the items on average. And so this Site 14 and in particular was one that we worked with because they are actually one of the best developed and longest lived wraparound sites in the country. And you can see that even in a site that is sort of nationally recognized as doing very well, they weren't scoring at the top end on every single item, but obviously also doing very well. So this is an example from one community of what, again, their overall mean. So the green diamond is the average of the total national average of the communities that have participated in the CSWI. And then the hollow diamond is their mean score. The little bars to the left and right of the score are a confidence interval, so that's a statistical confidence if that the mean lies somewhere between those bars. So in this case, you can see that this community, in terms of its overall score, was right about, again, if you look at the bottom, you can see that it's at sort of the midway of development and slightly above, but probably not statistically different from the mean of all of the other comparison communities. So if you look down the themes, you can see that the green diamonds don't all fall exactly at 2. And in particular, if you look at theme 3, the green diamond is the farthest to the left in that case. Fiscal policies and sustainability, perhaps not surprisingly, is an area that almost all communities find the most challenging. So that's why that diamond is farthest off to the left. Now in this case, the particular site 15 had even more challenge in that area than the national average, and they were significantly below that in terms of developing sustainable funding for their community. And then you can see in sort of in contrast in theme 5, they appear to have very strong development in the area of human resources. Again, that's supporting staff to do a good job with wraparound and to provide coaching and supervision and so on. And in that theme that they were substantially higher than the national mean. And also in the area of accountability and collaborative action, they look like they're doing pretty well. So that's sort of a theme by theme information that we're able to feed back, and then the communities can take this back to their whatever their community level board or planning or whoever's involved in strategic planning and oversight, and make a plan to try to address areas where there's particular challenges. And then just to give you another example here, this is within the human resources theme, theme 5. So these are the individual items from a different site. So this is even a little bit greater level of detail. So it looks like that in certain areas the community is doing very well. And particularly it looks like they're having, for example, in 5.3, they're doing a very good job of providing caseload sizes that are small enough that allow people to do a high-quality job in carrying out wraparound. But that if you look down at item 6, for example, in terms of compensation, the community consensus is that they're not providing compensation that's going to be able to retain people and in the field in their positions while they acquire the skills and ability to do wraparound. So then that's just the framework that I mentioned of the 6 themes is the framework that we use, and because it's to organize the information on the National Wraparound Initiative website. And when Bruce and Michelle are talking, they're also going to sort of structure their comments around the themes as well. The resources, just briefly, from the National Wraparound Initiative that are focused on this area of implementation support. We're working on a special issue of the Journal of Child and Family Studies that will summarize recent research around wraparound implementation. But on the website there we have these webinars. We have a whole series of supports that's specifically focused on implementation. We have a resource guide and miscellaneous resources as well that if you get our newsletter you will be alerted to those as they become available. This is just a quick screenshot of the National Wraparound Initiative website. Again, you've had the web address appear several times already and we'll be emailing that to you. But just to draw your attention a little bit more specifically to where you would go, under resources, as I mentioned, there's this implementation support drop down, and it has this implementation support, and then underneath it you can see these are the themes that I mentioned before. And we had again a big collaborative effort through National Wraparound Initiative members to identify some of the key challenges in each of these areas and some key sort of recommendations. So all of that material has been gathered under these separate tabs according to the different areas. And then we are also in the process of linking up more resources with greater detail. So this is an area that we plan to be building up over time as we go forward. Then just in general, also the resource guide, which is available from the navigation. You see here particular chapter 5 is all about supporting implementation. There are articles, in fact, about all areas of human resource development, about things like including MIS. In fact, that was contributed by someone from Wraparound Milwaukee. And then there are also areas about accountability and just a whole range of topics, a bunch of stuff on finance as well. So I guess this is just to generally show that you might want to check out the products and publications that are available from the National Wraparound Initiative on a variety of topics. And I think at this point I am ready to turn this over to Bruce. And so Sarah, if you can transfer to Bruce. Thanks. All right, take it away, Bruce.
Okay, I'm waiting for my name to appear, or anyways, but this is Bruce Camerad. There it goes. I'm director of Wraparound Milwaukee, and I'm pleased to be with everyone this afternoon. In kind of keeping with Janet's introduction, when she asked Michelle and I to do this, she asked whether we could utilize some of these emerging themes, particularly from a development stage, since Wraparound Milwaukee has now been around for 15 years, but really kind of thinking about it both in the current and in the past. How did these themes emerge? Were these themes really very important to making the development of Wraparound Milwaukee possible? So I've tried to fit it into those emerging themes, and I think it does fit very nicely. First of all, some things in general, kind of a general overview here is on Wraparound Milwaukee. In terms of how we're structured and organized, we're really a publicly operated care management entity and operated by the Milwaukee County Behavioral Health Division. I work for the public mental health system as head of children's mental health. So our model, and we'll be touching more on these things, is an integrated delivery of services across child serving systems. So Wraparound Milwaukee works across child welfare, juvenile justice, mental health. And we pool funding. We'll talk about that. We're a single payer for all of the particular services that a child and family needs. We operate from a one care plan, one case manager or care coordinator across systems. We're outcome-based, outcome-focused. We're family-directed and youth-guided. We use family-directed, very much a wraparound process that is based on family-directed, youth-guided care. And we'll talk more about this. We are a behavioral health carve-out actually for Medicaid, and we operate under a unique 1915A arrangement or a contract between Milwaukee County and Milwaukee County Human Services and the Wisconsin Department of Health, who operates Medicaid. Basically, Wraparound Milwaukee is, see if I'm trying to get this to move now. Let's see if this does this. All right. Oh, here we go. It is button. It is key down here. So anyways, okay, what did Milwaukee County look like in 1995? We'll start there and then get into the themes. But in 1995, when we started Wraparound Milwaukee, there were, at that time, separate child serving systems, separate child welfare, juvenile probation, and mental health services for children and families. We had reached, at that time, an all-time high for youth placed in out-of-home deep-end residential treatment centers. The systems combined had about 375 youth on any given day in high-end residential treatment centers. We had reached in 1995-96 about $18.4 million in costs, and there were $2 million a year in deficits that Milwaukee County had to make up through tax levy payments. We also had the Planning Council of Milwaukee do a report that showed that nearly 60% of the youth coming out of residential treatment re-entered the system, either child welfare or juvenile justice, within 6 months. So that was not good news to Milwaukee County. We were at that time operating an 80-bed psychiatric hospital for children. We had limited outpatient and with some limited outpatient and day treatment services, but not a really full continuum in the community. We had several new child and adolescent inpatient psychiatric units open up, and we had reached at that time in 95 240 inpatient psychiatric beds in the Milwaukee area. And the Wisconsin Medicaid program at that time was concerned with the dramatic increase in psychiatric inpatient days and increase in emergency room utilization for children, resulting in inpatient admissions. So at that time, the Milwaukee County Executive and County Board were publicly critical of their child-serving agencies regarding the increase in residential treatment placement and costs. And this kind of created the conditions, or I'll call it the perfect storm, for change and reform of the system. And one maybe theme that doesn't emerge is the opportunity for change. And sometimes that opportunity or the stars being aligned has to do with, as it did in Milwaukee in '95, some things that were going on that were really creating some issues for the child-serving, all of the child-serving systems. And then for us, it was the overutilization of institutional care, it was the increase in costs, and it was the poor outcomes for kids that were within that system. So that opportunity then propelled us really forward. So as we look at these emerging themes, and as I said, I may have added a new theme in creating an opportunity for change, is the emergent themes that Janet talked about that were tied to successful implementation of Wraparound Milwaukee. What did we do in developing Wraparound Milwaukee? How did these play a role? So I'm going to try to do these beginning with community partnership. And at that time, for us, community partnership and the steps really we took, at that time in the mid-'90s, I was actually director of the Child and Adolescent Treatment Center, which was our inpatient psychiatric facility. And we were trying to broaden out. We were trying to look at more of a community-based service model. In 1993, we had gotten an $80,000 grant to begin implementation of a small integrated services program. And we began with 4 staff. Today when we look at Wraparound Milwaukee, we have 110 care coordinators alone. So, but we started with a small group. And at that time, always important to have a key leader, and we had a key person at the state and children's mental health and state support, as Janet indicated, is certainly an important factor. But together at that time, that state partner, we developed and wrote one of the first SAMHSA grants under the Comprehensive Children's Mental Health Program. And Wraparound Milwaukee received one of the first 10 such grants. At that time, they were 5 years and $15 million, to develop a system of care in Milwaukee, created really out of the need, created out of the fact that we had so many kids in. One of our identifying issues was all of the kids we had going into deep end residential placements, correctional placements, and psychiatric hospitals. So, at that time, so one of the steps we took to develop Wraparound Milwaukee was to begin to basically assemble a group of individuals at the local level, as well as people at the state level, to begin looking at the key components of care that we were looking at that we had helped to start under the federal grant, and also to look at what was going on in some of the other states that was working well. That local and state team had myself, Mary Jo Myers, who is currently our deputy director at that time, our chief judge. They had a child welfare and juvenile justice, who was our chief probation officer. We got a number of people together to begin looking at that. But some of the components, as we looked at what was going well in Wisconsin or other parts of the state, or in other states, included the idea of mobile crisis teams, included the idea of having care coordinators case managers to facilitate child and family teams. The idea of having a comprehensive service array, not just a few categorical services, but to really develop a comprehensive array, that seemed to be the best way to individualize care. Family advocacy and support, the need to have family advocates to support families. So really through work with our local consultant, a national literature review looking at what was going on, we at that time became interested in the wraparound philosophy. In the mid-90s, in 1995, that was no given that you were going to move in the area of a wraparound approach. That was still very, very new at the time. But we brought at that time, we liked those components. We liked what we were seeing. So we brought people like John Vandenberg and Carl Dennis into Milwaukee, Mary Graylish and others to begin to meet, speak to, and work with some of our key stakeholders on a philosophy of care at that time, which we may take for granted now, which is the wraparound philosophy, but in the mid-90s was not so well known. So, and Wraparound Milwaukee's approach is really, you know, which we looked at pretty much beginning then, and which we maintain today, 15 years, is the 10 basic, you may say 10 principles of wraparound are very much our core values and principles today around individualized care, strength-based care, cultural competency, being community-based, harnessing and looking at natural supports, the strength and the central core being the team, child and family team, the importance of being collaborative across systems, being unconditional in our care, and looking at our outcomes, and if we're not getting the outcomes we need, to make changes in the process. But we very much adapted the wraparound process, and for 15 years have really stuck to that, and over time, at that time, tried to maintain and maintain a high-fidelity wraparound approach. But in 1995, the words high fidelity and wraparound really were not synonymous, because wraparound was really pretty new at that time. So some of the steps we really took to begin to develop Wraparound Milwaukee really were to begin a series of lunch meetings with our presiding judge at that time, with the head of juvenile court, child welfare, and probation, to begin to think about a different model of care for children in Milwaukee with the most serious emotional and mental health needs. There's a nice Margaret Mead quote about, it doesn't take a consensus of an entire community to change the system. Usually, and sometimes it begins with a few people, and oftentimes that's where change starts. And that was really very much our case, is that it really started with a group of meetings that, with some key stakeholders over lunch, to just kind of think about how we would change that system. And simultaneously, we began having meetings with the state Medicaid agency, with our state children's mental health director, and begin to bring them into our group of small meetings. So several separate efforts really converged into kind of into a coordinated approach as we begin looking at the history. Very early on, as we were developing Wraparound, we made some key decisions about family involvement that have worked out well for us. One obviously is to, in our model, families would direct the care planning process, which is obviously, as we know it today, the child and family team process, but that was very new back then. We were going to involve committees, as we do today, families in everything we did, all our committees, work groups, training of care coordinators, working with providers, evaluating what we do. All of that would be family-driven. We went in a little different direction. At that time, we had no local organization. We had a state organization. But the local families in Milwaukee really wanted their own organization. So we supported a group of local families to develop Families United of Milwaukee, and to this day contract with them to really develop and to really run our family organization in Milwaukee. So we really finance that. They've at times had other dollars coming in, but it's been a key part of that. We don't use quite the same model as the New Jersey model, which developed after Wraparound Milwaukee. We don't use a parent partner for every single family. That's pretty much their choice, whether they want an advocate or not. Another key thing was in 2006, we added a component of educational advocacy services through Families United, which has been hugely successful in securing and helping our kids receive individual education plans, finding school placements, reducing the need for day treatment services by getting more kids back in their school. So those were some key decisions. Now another theme is around collaborative action. So how did we then proceed here and collaborating across systems and taking action? We went with with our small leadership group from child welfare, juvenile justice, and mental health to test the components and philosophy of wraparound, and whether or not, even though we had a federal grant and we had dollars from the federal grant, we really needed to convince them that this process and approach could work. So we developed with them a pilot project we called the 25 Kid Project. There was no eject or reject. We funded it through some of our grant monies, through Medicaid, targeted case management, through some fee-for-service, through some other strategies. But the idea was we would take 25 youth with no immediate plans of discharge from residential, and the idea is, could we get them home could we get them home and successfully keep them there? And we were really able to get 17 of the 25 youth who had no immediate discharge plans home in 90 days. And a pilot project can be very important in terms of a collaborative action. This pilot project went a long way to establish the credibility that the wraparound, using the wraparound process and the components that we were putting into place, could be successful with this high needs group of youth. And that really got child welfare and juvenile justice on board and looking at this model as an alternative for all SED youth, in the community. So from them, in terms of collaborative action, once you develop a pilot, you always have to make sure that you've designed in your pilot, the ability that if you are successful, how are you going to sustain it? How are you going to implement it and expand it? So we had 25 kids. We had 350 to go that were alone in residential care. So with the help of a managed care consultant, we really costed out the potential costs of then going to more of a community-based model of what it would cost if we basically took all the 350 remaining kids into the system. So, and we'll talk more about creating winning scenarios, but we proposed a case rate to child welfare and juvenile justice, which was an alternative to what they were paying to send kids to high-end residential treatment. We gave ourselves 18 months to enroll then every existing youth in residential treatment, plus every newly identified youth needing a residential level of care, and gave ourselves 18 months to work across those systems to enroll all of the youth in Wraparound Milwaukee. It didn't mean that every youth would be out of residential. It just meant that if they were there, they would be under the auspices of Wraparound Milwaukee on this newly created system of care. And Milwaukee Wraparound, which was part of the Children's Mental Health, public mental health system, would agree to assume the responsibility and risk for all of the RTC placements and costs at that time. Now, knowing this was local from a state perspective, we had already mentioned that we had state support in terms of getting their key mental health, some key mental health people on board. But our next steps here from an action perspective was to really get Medicaid on board. Now we have local child welfare and juvenile justice. But we knew for this to be successful, we needed the state Medicaid agency to be on board. So we basically proposed to Medicaid to utilize, we began with the use of our mobile crisis teams our initial mobile crisis teams that we were developing under our grant to utilize to reduce psychiatric inpatient care. We got Medicaid to agree. You can always design these kind of uniquely. We got them to agree initially to pay us the state portion of the rates they were paying to hospitals, including our own, if we could divert these children for at least 30 days. It was an interim approach until we got our capitated arrangement with Medicaid worked out. But it proved very successful. We almost immediately were able to reduce another 20 beds of inpatient capacity in our own public facility. And just like in child welfare and juvenile justice, our ability to divert kids using mobile crisis and some of the other services proved very effective in helping us to negotiate more with Medicaid. Dane County, Madison, and Milwaukee County, Dane County being the second largest county, began negotiating with Medicaid in '95 to create a behavioral health carve-out in the two most populous counties. We used what we called a 1915A and created a voluntary managed care program for this group of defined youth. Basically, that provision, the 1915A, allows you to create a voluntary managed care system. It's a unique portion that most people don't realize is part of the Social Security Act. It's very different than a 1915B. But where our ability to access child welfare and juvenile justice funds, plus the potential of reducing residential treatment, was really very important to Medicaid to actually move this forward. We worked with Medicaid and their actuarials and offered that we would do this at 95% of what they deemed their actuarials said were the per month child costs. Milwaukee County ultimately, I know there's a lot of stuff here, assumed full risk to do this. And we basically then created this very unique CME care management organization and created Wraparound Milwaukee as a special managed care entity. With all of these functions, screening and assessment, enrollment, care coordination, crisis intervention, clinical oversight, all of these things would be roles we would take on. But I want to get into that finance sustainability, which, as Janet said, is a huge piece of the puzzle. What we created in Wraparound and maintain today is to create a blended funding pool where Medicaid, child welfare, delinquency all would pool funding through various rates. Medicaid through capitated and certain fee-for-service arrangements, child welfare through that case rate, and delinquency and court services began under a case rate and now do fixed annual funding. Our principal approach was to redirect money from institutional to community-based care, which I still think is one of the best strategies to use. We used this 1915A. We made Wraparound a single payer of all of the service costs because we were, after all, pooling all the funding. We would utilize a very broad provider network, paying providers on a fee-for-service basis, and we would link every provider through one IT system, which is we developed in 2000 under our synthesis to go to one electronic. And how we did that, Janet mentioned there is a within the NWI a paper we did basically on developing IT. But in doing this, from the very start and what we do today and what I would encourage, if you can do within your community, if you're going to pool money, you got to create a winning scenario. And basically what we did is for every system created a win-win scenario. So for child welfare, it was creating a win-win scenario to their out-of-home residential costs, which were high cost, poor outcomes. And the case rate was developed initially at $3,300. Today it's $3,900, which would be a lot less to them than the cost of institutionalizing a child in residential. which when we started was $5,600, but today in today's world would be about $8,600. To Medicaid, we had to give them an alternative to high inpatient costs by saying we would create an alternative and to increased inpatient psychiatric hospitalization and reduce their emergency room costs through basically having an alternative to hospitalization, the use of our mobile crisis teams. We could basically reduce that. For juvenile justice, it was creating an alternative to detention costs, to their high costs of placing kids with delinquency in residential treatment, and it was an alternative to incarcerating children in state correctional facilities, which in Wisconsin is charged back to the local counties. And for special education and education, it was creating mobile crisis services in the schools to reduce out-of-home suspensions, stabilize kids in classrooms, provide an alternative to day treatment services by getting and keeping more kids within in the system. This can vary. This kind of scenario can vary in your county, but this worked very well for us. Without going into great detail, when in the pooling of funds, basically you can see what I've talked about, which is how we pool funding comes into Wraparound Milwaukee as a single pool of funding is made available to all of the teams. The dollars flow to the child and family team, facilitated by the care coordinator, determine what that child and family needs, develop the plan of care, and for any formal services that are identified as a need, a strategy to meet a need, be that anything from any type of service is then secured through a network of providers. The providers bill back Wraparound Milwaukee, and everyone within the system is put onto one basically electronic health record to automate everything so that you have electronic. And basically, we have created today a paperless system to do all this with everyone on one IT system. The advantage of pooled funding, I won't go into, is flexibility, gives you much greater adequacy, decategorization of funds so you can truly individualize care. It's responsive to changing needs because the dollars can be moved, they move to wherever the need is. Lends itself to managed care approaches and really depoliticalizes. Access to support and services. By creating and creating this pooled funding, you can create a much broader, what we call benefit plan. These are just a few of the 70 services that we made available and make available today. So with these $2 million, you can use it for all the various funding. I want to mention, too, there is going to be, because we were interested, and they are going to put a poll up for all of you following on the financing side particularly, but it will talk about, basically, we'll ask you what, we'll poll you on what system has been the most difficult or what funding source has been the most difficult for your program to engage. We're interested in kind of a follow-up on that. So every system may have some differences. So we'd like you to select one, and we don't vote on them, but if you could kind of let us know, that would be very helpful as we move forward to where the most technical, where NWI should maybe be focusing on providing technical assistance.
All right, so we've got 37% voted right now, so we'll leave the poll open for a little bit so everyone can get their answers in.
All right, I'll move on from the quick poll here. I zipped myself out of my own little, so anyways here.
Yeah, we'll let everyone vote before we can switch the slides again.
All right. Reload on here. So.
There we go. So let's share the results real quick. All right. So it looks like at 33% Medicaid was the highest answer choice.
All right. Well, that is good to know. Okay, so we'll move on then to the next slide. Talking a little bit about the provider network, and I know I want to give enough time certainly for Michelle, but one of the things that has been very important to us was to create a very broad provider network. We have a lot of different services. We don't use formal contracting. It's been very important to have extensive quality assurance. One of the things that was very important to work with residential providers to re-engineer services. We offer consumer choice. As I said, all providers are linked basically through one system. So now it's not letting me move my slides. So perhaps you can move them there. It just took my command away here. Advantages of fee-for-service, cost, flexibility, levels the playing field. Competition promotes quality, depoliticalizes contracting. So it was very important to basically create a provider network in Milwaukee to allow us to do that. Why don't you do the next slide for me? There we go. Human resource development, another key piece to all of this. I mentioned mobile crisis. You have to have the key pieces in place. It was very important for us to have mobile crisis teams to do our 24/7 crisis intervention and to be our gatekeeper on inpatient psychiatric care. Mobile crisis teams have been very, very important to Wraparound to help us maintain our crisis safety plans and provide us with a wide range of different services. Care coordination, another human service resource, very important. As they meet with the child, do our strength-based inventory, convene our child and family teams. We operate with a very low our caseload or our number per family. We average 1 to 10. That's a maximum for regular wraparound. We allow for our non-court involved youth to have basically 1 to 14. Our care coordinators in our system actually also do they meet with our team, do our child and family team, prepare a written plan of care, searches for community resources. They authorize basically the paid services based on what the child and family team really identifies, attends school meetings, coordinates our plans with probation, child welfare, advocates for our families. Human resource-wise, our care coordinators have been a really important part of, and they're a key part of the Wraparound Milwaukee program. Also, in our sense, we use legal. They have many legal roles in our system, since we get a court order. The care coordinators get a court order through child welfare and juvenile justice for those youth that are involved in those systems. So our care coordinators actually go to court. They actually help develop court reports, and the judges look to them to be present there if the child is involved in those systems. And 2/3 of our kids are involved directly in child welfare or juvenile justice. Kind of getting through this in terms of accountability, which was another of Janet's, another of the themes. Quality assurance is very important. Fidelity issues that we look at through our QA/QI program is really around functioning, living arrangement, community safety, school permanency, family satisfaction, use of informal, formal supports, family activities, face-to-face contacts. All of these things are critical pieces that we measure and we look at as part of our team process. Process indicators, plan of care submission, progress note submission. I'll let you look at all of these things are things that are critical decisions around QA, QI, and are critical to maintaining an accountable system. We look at our electronic system, which is also very critical to providing us with the information so that we can remain accountable to our stakeholders, is having one IT system that's available to collect all of the data we need. And that is through our synthesis IT system, of having one information system, and everything basically we do is off that system. So everything is done electronically, progress notes, care planning, all the authorizations, payment invoicing, report writing is all done on one single electronic health record. So that's been another piece because we can provide that information and data to our system stakeholders. I won't go into any more in the synthesis system, but providing outcome information. What has helped Wraparound Milwaukee is the ability to basically get the kinds of outcomes that stakeholders have found important. We've reduced residential. We've reduced inpatient psychiatric care. We've reduced juvenile correctional care in Milwaukee County through the number of youth that have gone into and utilized Wraparound Milwaukee. It costs less for kids to be in Wraparound Milwaukee. That's been hugely important to our stakeholders. In fact, Child Welfare and Juvenile Justice today, their contribution into the wraparound, which is about $20 million, is their same contribution that they were paying for residential treatment alone in 1995. So that's been a big piece. Had we not, the cost of doing nothing shows that today if you just did a 5% rate increase and 5% increase on the number of placements, that without Wraparound Milwaukee, those two systems alone for residential could be contributing $63 million today. So it's the business argument that you can make in terms of what systems of care operating under Wraparound can achieve. Outcomes have been better, safety outcomes for kids, and in the system. So I think these have all been very important in terms of accountability. Clinical outcomes for kids have been better, and school attendance has been better. So all of those things have really been critical to us. So I'm going to switch over. I don't know if there are any immediate questions, but I want to give Michelle time to do Maryland.
Well, thanks, Bruce. And while we're switching over, I think we should probably hold questions until the end because we're running a little bit behind. We should have some time for questions, and so if you want to, we're going to be holding those. Thanks.
Okay, thank you. I'm really happy to be here today. I have presented enough with Bruce that I think I can make up the time, and we should be able to do questions at the end. So what I wanted to do today, I was teasing him earlier that going after Wraparound Milwaukee, kind of being the mothership of Wraparound in the nation, is a little difficult. So I'm going to do my best to give you a sense of some of the lessons learned that we've taken from Wraparound Milwaukee, tried to apply to the state of Maryland, and then the differences given the context that we're actually living in. So for those of you who don't know Maryland, I am trying to get this to move. There we go. Nope. There we go. For those of you who don't know Maryland, I think the important thing for this presentation is to know that there are 24 jurisdictions in our state that make up rural, suburban, and urban. We have about 50% of our public mental health system currently being spent on kids 0 to 21. And this, for us, has been an exciting opportunity. Oops, I'm still getting used to this, guys. I'm very sorry. This for us has been an exciting opportunity because the efforts that have started in Maryland have actually lasted through 2 administrations at this point, which for all of those, for those of you who are on the phone know that that can be in and of itself an amazing task to pull off and maintain consistency and support to really make wraparound implementation happen. So it really was in 2005 that Innovations Institute was, all right, please forgive, that Innovations Institute was developed, that some of the organizational structures to support the state's efforts around system of care implementation happened. But I want to point out very clearly that just like every other state in the nation, we have had a number of iterations of really good efforts by local communities in Maryland attempting to move our systems forward. We were one of the first states in the nation who received a system of care grant. It was here in Baltimore City, and it was really then that the state of Maryland started to kind of stick its toes in the water to figure out what wraparound meant. We, like most states, had John Vanderburg here and many, many people trained, and although there was a good faith effort to move forward, you know, it really wasn't sustained. And although it lasted for a while, it wasn't a sustained model, and it ebbed and flowed. In 1999, Montgomery County of Maryland received a system of care grant and really put together an amazing care management model and wraparound implementation, family support. And because of the commitment of these communities and the evolving family organization in the state of Maryland, there were some really solid conversations started with the state, and, you know, starting in around 2004 and then going into 2005 when system structure started to be put into place to really begin to pilot out what we thought might work best in Maryland. It was interesting to hear Bruce talk about the lunch meetings. In our state, they were actually breakfast meetings, and they lasted for quite a while. And I'm wondering, we should have actually asked the question, who has breakfast and lunch meetings to make their systems move forward? Because it's those kind of relationships and activities that a lot of times can really organize and motivate people. Going with Janet's themes, I just wanted to piggyback a little bit on Bruce's comments. So when you think about Wraparound Milwaukee implementation, it has been an amazingly successful, groundbreaking implementation for Milwaukee County. And what the state of Maryland is really attempting to do is take the lessons learned in our early adopter communities, Baltimore City, Montgomery County, and then we had some early pilots in 2 rural jurisdictions, St. Mary's and Wacomico County, and really take those statewide. So as I was kind of reviewing the themes that are in the National Wraparound Initiative and thinking about how to connect some dots, in some of the literature, there's conversation about, you know, do you actually restructure or do you use current mechanisms? You know, what are some of the ways that you're going to create community partnerships and organize yourself? In our state, we felt like we had a fairly good organizational structure by which collaboration and communication occurred. So on our state level, we're a state that has a children's cabinet and a staff support in the governor's office for children. And it's through that entity, the Children's Cabinet, which is a sub-cabinet to the overall governor's cabinet, that an interagency strategic fund or a Children's Cabinet fund is actually organized. And it's those dollars that have been used to seed and supplement the activities that are going on in Maryland right now. We also have a similar structure on a local level. They're called local management boards. And they really are kind of the equivalent structure to the Children's Cabinet on a state level. So it's those groupings of collaborators and partners that have been the organizing bodies by which these activities have happened in Maryland. In about 2008, Maryland had, like I said, actually it was 2006. We had a party change and a change in leadership, and a group of secretaries came in to be part of the Children's Cabinet who had very similar and consistent views about kids' services. And when they looked at the data in Maryland, there were some fairly congruent concerns around how much group home utilization we had, how much RTC utilization we had, and it was within that second year, 2007, that an effort happened in Maryland that has really kind of set the course and helped us sustain this overall systems reform effort and statewide wraparound implementation, and it was our state's interagency strategic plan. That strategic plan was really the opportunity that we took to, I'm not really good at this. I'm not sure I should have taken this over, Bruce. The opportunity that we took to get everyone kind of to voice their opinions, to organize around common themes, and it was through that process that the message was clearly sent from a local community level that a statewide wraparound effort was really supported, that Maryland was kind of tired of there being pilot sites. We wanted to move out of our pilot stage and on to full-time implementation. So I'm going to move a little bit into some more structures in that and clarify for a second about how we think about our care management entities and some of the information Bruce gave earlier. So Wraparound Milwaukee has really been the model that we've looked to. In our state, however, we have an administrative service organization that has all the functionality that is described on your screen: care authorization, provider credentialing, enrollment, etc. They are not at risk, so that it is not a managed care model in the purest sense, but they are here as an arm of the Medicaid system and mental health system to ensure that access, utilization management, CQI functionality, all of that occurs. In Maryland, it's a whole population ASO. So it's a birth to death model, and out of that there really becomes this emerging need to have something that will work with kids and families who are cross-system involved, at risk for out-of-home placement, so on and so forth. And so we've taken really a lot of the same functionality that Wraparound Milwaukee has, and although you see it a little divided between the ASO and our care management entity. The other thing to point out is that I think Bruce and I are very clear that we were asked to talk specifically about supporting WRAP implementation, but that second part of the title, Emerging Themes for Developing Your Program or Systems, you're hearing us both talk about this conceptualization of care management. In our state, we've really understood this care management model and the development of this organization as a true benefit to assist us to not only implement high-fidelity wraparound, but to create the system structures and the continuum of cares and the resource development needs. We have the same kind of responsibilities embedded within them that Bruce mentioned, that include web-based information systems and so on and so forth. This for us is really the place that we are expecting to be the locus of accountability for the populations that are prioritized by the state. And we use Wraparound as the practice model to ensure that all of the values and principles of our system of care are implemented on behalf of kids and families. So the same process of a single plan of care, really using all the life domains, strengths-based, linking strengths and identifying needs, linking strengths to strategies is the same approach that we take. And for us, we have moved statewide effective December 28th of last year. So as Bruce reminds me, we are the new kids on the block, and we have, as we know, a lot of lessons learned that we still have to muddle our way through to make this really be full implementation. But we have 3 regions in our state. The funding all comes through the Governor's Office for Children, and the process is really that at that Governor's Office for Children level, the funds are blended, and there's a single contract with the care management entity. So all the oversight and processes are established by a cross-agency team, and then that same model is, again, at the local level, as I talked about a little earlier. We have actually also identified populations, and then given the financial context that we're in right now in Maryland, gone after multiple grants to try and keep us moving forward in these tough financial times. So I would consider this for us in Maryland kind of our first iteration of making this happen, with a clear goal of having a case rate at the next iteration that we take. So we clearly understand that the financing structures that Bruce talked about earlier is really one of the best methodologies we can use in our state to really buy outcomes and ensure that we can keep kids in the appropriate level of care. But we also are pretty opportunistic in the sense that we'll take our state-only funds, we'll take our Medicaid funds, we'll take any system of care grant dollars we can get, and anything else we can get to actually blend and put into this system to expand. And there's real interest and political will behind this at this point that, as we move through this first iteration of full state implementation, all eyes are on this project, and so far really good outcomes and things are happening. So we expect, as we do maybe another webinar like this in the future, that we'll be able to talk a lot more about how in a statewide implementation we're really surviving. Another element of the themes that Janet spoke about earlier is really how to make this last on a statewide level. And you can hear from the story of Maryland that there really is true state support, that the community partnership elements are organized and moving forward. But we also have taken this opportunity to really write things into policy and regulation to ensure that this evolution in our state really lasts. So we have actually written into Medicaid state regs the definitions that talk about care management entities, what an actual wraparound service delivery model looks like, child and family teams, and it goes on to include information about strengths and needs of the participants in child family teams and their families. We've also taken time to embed definitions that include care coordinators, and we are using that term, I think, interchangeably with WRAP facilitators, peer-to-peer support, care management entities, so on. You can read the list yourself. And then those same definitions and information are being embedded in the mental health systems regs as well. There's cross-references. So we wanted to ensure that as this evolution occurred for us, that really it was long-lasting. And we all know that when you write things into regs, it takes a lot for other people to come behind you and unwrite them. So finally, the one thing I wanted to also mention is we've rewritten the medical necessity criteria in Maryland, which up until this date really was clearly about going to a bed in a licensed residential facility, and the new definition actually talks about a level of intensity that is could be about community-based care and utilizing a wraparound process to really create a full plan that can serve a kid in the community as an alternative to a bed. And that has been really an interesting evolution. We're doing many, many webinars, talking with many, many psychologists and psychiatrists, the prescribers for a lot of this work to really move the conversation in Maryland along to be able to have, all the communities of practitioners that are out there supporting this effort on the same page around this community model that we're really committed to. In our state, I mentioned earlier the idea of the interagency strategic plan, and one of the main areas that people were very, very focused on was this idea of a continuum of care. So what's interesting is a few years ago when we started this initiative, we took Milwaukee's overall list of services and supports that are available in their continuum and crosswalked it across the state of Maryland. And in all aspects, every one of those services is available in our state. The issue comes down to availability at the appropriate levels across all regions, and that there's really statewide access. So the effort in Maryland right now is about really bringing up both evidence-based practices and services and supports that are available across the state. We really do have in our rural jurisdictions a lack of community-based services to date, and a plethora of services in some of our more densely populated areas. And so for us, this is about a few years of an effort to really redirect funds, create community service arrays that are reflective of the needs of the population, and build it up so that the wraparound implementation support can occur and be really effective. To ensure that that is connected to our care management entities, all of the care management entities have within them resource developers whose job it is to really go out, beat the bushes, know the services and support array, have web-based tracking of that, ensure that they're connecting providers to plans of care, that we're really creating services that are identified as needs on plans of care, not just creating to have. And we expect that over the next couple of years we'll really have a different landscape in terms of the continuum of care in Maryland. So I'm going to check our time real quick, but and I'll try and do my best to get through it in the next 2 minutes. One of the things that Innovations was really created for was the idea to support the human resource development in Maryland. We have multiple, as most states do, we have multiple initiatives going on across juvenile services, child welfare, this wraparound implementation, all related to the idea of moving our workforce to owning and understanding community-based care models. And a lot of that work happens, in terms of training, technical assistance, and support happens here at the University of Maryland on behalf of the state. So we have a really good collaborative effort with the Child Welfare Training Academy and so on, and really live by the idea that we're not just transferring values to folks. We are really trying to impact their knowledge, their skills, and then their abilities so that kids and families are affected in a positive way by all of this work that we're doing. In Maryland, the state has invested in a wraparound certificate program. Wraparound Milwaukee has certainly been a tremendous partner to us in creating what that model looks like. So all the folks who are involved in WRAP implementation, those facilitators and family support partners, are going through a certificate program. And I know there's debate out there in a lot of states as to whether certificates really mean anything, and certainly we understand that certificate program doesn't mean that everything has changed for you. In our state, we're big certificate people, so this is a way for us to both hold the care management entities accountable, really ensure that their skill sets developed, and show the kind of state process that folks are moving their practice forward and are of the skill set that we want them to be at to really be good facilitators of the wraparound process. We have other certificate programs that are supported by the state of Maryland and a few more to come, all related to the idea of improving the workforce so that kids and families can really be supported in their homes and communities to the best of all of our abilities. At the same time, we have an evidence-based practice implementation approach going on, and we are really early on where, we look to states like California and Ohio and others to really be in conversation with around the integration of evidence-based practice with our wraparound implementation. And many of the models that have been the most easily joined have been trauma CBT, functional family therapy, some of the parenting approaches like Triple P and others. But all of this is happening in Maryland in the context of keeping kids and families in their own homes. So you can see that we're a truly busy state. We are really excited about the implementation statewide of wraparound. We feel like given the current context of state budgets that we have had a big coup in making this happen and sustaining it and gaining the support that we needed and really moving it forward. I said to you earlier, we've been very opportunistic. We've looked at our own methodologies for spending funds. We're in, every year doing a better and better job of braiding and blending funds to move us forward. We'd like to get to the point of having risk-based financing and feel like after we get a little bit more time under our belts, the state will be very interested and supportive of that model. But we're also clear that we're in the midst of healthcare reform and really linking all of these efforts to the national model, national efforts around healthcare reform. So we also are a CHIPR grant state that is really looking at care management models and how to ensure that the public mental health system and the wraparound care for these kids and families really is linked and supported, and we're moving it all forward in a positive way as we move into kind of the next evolution in our own system. I gave you a quick summary of all the funding that we've blended to go into the care management entities, and then I think we are to the point that we have a little time for questions.
Well, thanks, Michelle, and thanks also to Bruce for being here. I'm sure if we had everybody audible, they would be clapping or perhaps even providing a standing ovation at this point. So I'm going to ask some of the questions. I have some hands raised here. How come that's not showing me the list of hands raised? Okay, so I'm going to ask, I'm unmuting Laura Berger-Lucas. Do you have a question? Go ahead and speak.
No question, Janet.
Oh, okay. Okay, no question. So I have Joan Fletcher with a question. Joan, are you there?
Oh, yes, I'm here.
You want to go ahead with your question?
The question that I had, I heard someone say that they have a program where they have breakfast and lunch for the systems of care. They can have a meeting, but I didn't hear about why they have that.
Well, we did it because it was an easy in Milwaukee. It was a good way to get people to get together. Was over lunch because it was it was a free period. It was some free time where you could get the judge, and you could get the head of child welfare. It was just same thing with breakfast. I'm sure with Michelle, it was just a time and an opportunity to get people together in a setting and at a time where they're more at ease to do some to think about how they might change and change the system, their system. So it was just a good opportunity to get people together.
Yeah, I think for us, there's the pace of this work is so fast, and it's so difficult to get leaders scheduled very regularly to think. People are just reacting and moving, and it's hard to sit and think and find space. And when we worked for about 3 weeks to get the key leadership that had to really get on the same page to move this forward together, that nobody has the same schedule. So people, I think, really nobly came in at 7 in the morning about every 3 weeks to have breakfast together and really, before the day got crazy and think and really plan and take the lessons learned from the local communities and the opportunities they knew were on a state level and really, take a planning process very seriously. And I was, half joking that we both did it over food. I'm sure other people do it in a lot of different ways, but for us, it was the time of the day that people could still think strategically and not just react to all of the things that go on, with our leaders every day. So.
Okay, thanks. There's a couple questions I have here about the mobile crisis. So one says, was there any specialized training for your mobile crisis team based on wraparound principles, or was the training more traditional? The other question is, how is the mobile crisis team funded? So Bruce, maybe if you could handle those two.
Okay, our mobile crisis team is it's a little of both. They all possess good clinical skills, but they're working within a wraparound framework. So the wraparound training itself is very, very important, and a big fundamental part of that is doing good crisis safety training. How they are funded, great question. We have HFS 34 was created by Medicaid, by the state, and Medicaid follows it, and created the crisis intervention program, mobile crisis teams in the state of Wisconsin. They get funded through Medicaid has a fee-for-service fund schedule available. Fee-for-service meaning there are different rates charged for different performing providers. Wisconsin Medicaid covers the mobile crisis team. They also cover what is called optional crisis stabilization services, which is one-to-one crisis stabilizers working for the crisis team that go into the home. And we also have for treatment foster care providers and group home providers, Medicaid pays the non-room and board costs for crisis stabilization services that are provided in those particular facilities. So that's how it gets funded. Wraparound can pick it up with the dollars we get also through our pooled funding, but that has helped dramatically with funding our services. And I know Maryland also has created some of these in their system.
Yeah, I was going to say, I think many of us have replicated the team model. I mean, I know that Westchester, New York, New Jersey, and other, have really looked at the structure, the training methodology, the kind of, the move from traditional crisis services as the system has known it to really a kids crisis, this kid and family crisis system. I think that the model that was originated in Milwaukee is really giving good success. So I think people should go visit.
Right, and we thanks, Michelle. And we do get we have a contract with Child Welfare for $700,000 a year to have 9 dedicated workers to do all their crisis intervention work, and we do the same thing for the public schools. We have a $500,000 contract with them. We have 6 crisis workers in the school. So they wanted to go farther. They wanted to have dedicated teams just available in those settings. So it's amazing how you can do this, and how important that service can be for those systems. So I would encourage you guys to kind of look at those models because they have been really important to those other systems.
Okay, so we have another question here from the Human Resources area. Are facilitators of Wraparound required to have a BA or some other educational attainment, or is a combination of formal education and experience permitted or encouraged in any state or area programs?
In Wraparound Milwaukee, it's a BA or a BS degree. It's not. You do not have to have a master's degree. However, we can make some exceptions. We have had in some situations where the family became their own care coordinator, and we have done that in some situations.
We have the same bachelor's level requirement in our state. Yeah.
Okay. Any thoughts or experiences with similar community wraparound issues with very young children under 3 years old and their families?
Our usual youngest in Milwaukee is we've had some kids as young as 5. Normally we don't have that many kids under that. However, that is if you can make such a model work with younger kids, if you can get that model funding, if that's a presenting problem in your community, kind of go for it. And it's just simply that we don't see those kids. If you remember in Milwaukee, our focus was on alternatives to kind of residential treatment and hospitalization, and that's really, we don't really see that the 0 to 3 population. We don't see that many in that cohort of children. But I certainly encourage communities, if that's a presenting issue, and you can figure out how to get the support and the funding, to do that, then, go for it.
We actually have an early childhood system of care initiative in Maryland that really obviously, and those of you who work in early childhood know this, that the partnerships are just an entirely group of different people than what Bruce and I spent time talking about today. And the intervention approaches that the systems can use range, and so we also have not necessarily taken kids as young as 3 into care management, but we've used other models of, really still embedded with wraparound values and principles, just different approaches than the care management model that we're using in Maryland right now for the older kids.
Okay, I have a question here. Are all state statistics for reduced need of high-end services posted on the Wraparound website, or our team could use this information? Not all states collect this kind of information. The Wraparound website does have the resource guide has a whole section on research, and there are several new things on the National Wraparound Initiative website that are summarizing peer-reviewed research on outcomes for Wraparound. And in the resource guide, there's a review of additional research. The thing is that there's a lot of information, for example, in the slides that Bruce presented today about outcomes that's not necessarily been written up formally. And of course, there's new information from that kind of program evaluation coming out all the time. So I guess the answer is that there's a fair amount of published information, and there's more information out there, although you have to sort of look a little harder for that. We are trying to collect some of that with the National Wraparound Initiative, and if you become a subscriber to our newsletter, we'll let you know about when that becomes available. We have another question. Are family partners utilized in your wraparound system? I think Bruce already spoke to this, but I can't remember if Michelle talked about this.
In Maryland, we do have family peer-to-peer support. We also have navigators. So we really have been working to develop kind of our own continuum of family support models that would, be available to families at various levels in the system and their own needs. We don't have a model that looks exactly like Bruce mentioned New Jersey, where they've really developed in every local jurisdiction a family support organization, and then a much higher ratio of family peer-to-peer support and care coordination. And we don't have quite that level of intensity, but we do have it available, and we're committed to it. Yeah.
Okay, well, I'm going to real quick ask a couple more questions from the people who have their hands raised, and unfortunately we've already run over time a little, so I'm going to just ask a couple more quick questions, and I'm sorry, but that's going to have to be it. So I have Pablo Bastida. Are you there, Pablo? Going once. Okay, well, I guess not. Jeff Tintzman? Jeff? Hello? Well, it sounds like Jeff might be having audio problems. Okay, one last try here for Sherry Melrose. I guess our hand raisers are maybe not having their audio fixed quite right. Okay, well, I'll give one more question here. What IT program did you use, and could you talk more about the data that is entered? Is it client-specific or more for statistical purposes?
In Wraparound Milwaukee, we developed in 2000 our own software system, Synthesis, actually, which is now used in Cuyahoga County, Cleveland, and Arizona just recently purchased it for theirs. But we developed it to be very wraparound friendly. So first of all, it was developed really with the assistance of all our care coordinators to follow exactly how and wraparound. So it's very much in inventorying the child and family strengths, doing the crisis plan within there, doing a domain-based plan of care. We've gone a little further in that. All the services basically, for instance, are authorized through that system because it's an IT-based system to link everyone onto that system. So our providers actually get their authorizations. They bill online. All the progress notes are done online. By that I mean we started with our crisis providers and crisis stabilizers. All of our out-of-home providers, foster home, residential, group homes, they do all of their notes online. We're now moving to do the notes of the clinical providers online. Not to be confused that they don't maintain their own, their own clinical notes, but they put a note online related to progress they're making. So our idea was to put it all online because our progress notes are also automatically for those in certain areas where we bill Medicaid. We're capitated for most of our things. For instance, in the crisis aspects, those get billed fee-for-service. So progress note is also the billing document, and we bill automatically. Synthesis bills Medicaid directly off those progress notes. So that's really what we're doing on IT. And if you have more, specific questions, I'd be more than happy if anybody wants to email me.
Okay. Well, I want to be respectful of the time of everybody who's joined us, and particularly our presenters. We're very grateful that they were able to be part of this webinar today. And thanks to everybody who was in attendance. Again, the slides will be posted. The slides separately, as well as the whole webinar over again. You can listen to it again. Will be posted on the NWI website, and we will send an email to everyone who was registered for the webinar when that's available, and you'll be able to just follow the link and get there very easily. So thank you very much to everyone, and I hope you have an enjoyable rest of your Tuesday. And a special thanks again to Bruce and Michelle. And that's it for us. Thanks.
Thank you.